Good evening and welcome to session 2 of our virtual patient education series, 2020 New and Emerging Treatments for Blood Cancers. My name is Carrie Callis. I'm the Director of Programs at the Leukemia Research Foundation. We are pleased to present this event in partnership with the Cardinal Bernardine Cancer Center at Loyola. We're grateful to have our presenters this evening, Dr. Sonali Smith and Dr. Nasheed Hossain. We would also like to thank our supporters of this program, AbbVie, Jazz Pharmaceuticals, Karyopharm Therapeutics, and Novartis Oncology. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures and enriching the quality of life of those touched by these diseases. Since its inception in 1946, the Foundation has funded over $80 million of research grants to over 500 new investigators on 5 continents and supports patients and families living with a blood cancer diagnosis through educational and support programs. I encourage you to visit allbloodcancers.org to learn more about our patient support programs, including our online support community and our comprehensive listing of resources. We are going to start with by introducing Dr. Sonali Smith from University of Chicago. Dr. Smith, welcome. And if you could just say a few words and go ahead and start your presentation.
Absolutely. Thank you so much to everybody for having me here. Thank you, Dr. Stiff, for inviting me. I have participated in the live event several times and really enjoy and appreciate all the great questions and all the interest. And I'm very grateful that all of you are here tonight to talk a little bit more about lymphoma. So I was tasked with talking about aggressive B-cell lymphomas. And what I thought I would do is give a little bit of a primer. I know that normally when we meet, it's not really a lecture. It's really more, discussing questions and things like that. And I think for this particular group, I don't know that I've ever really been able to go over some of the basics, but I thought it would be a good way to set up the next presentation, which I'm really excited about. So I'm going to talk about aggressive B-cell lymphomas and give a bit of a background. I think I know, or at least I've been at this before, but just for those of you who don't know me, I've been at the University of Chicago for 22 years now and director of the lymphoma program for the last 10 years. So this and CLL are 100% of what I do and really have a passion for trying to figure this disease out. So I'll start with what is lymphoma. Lymphoma at its core is a family of blood cancers derived from mature lymphocytes. Lymphocytes, which come in 3 flavors, 2 flavors, B cells and T cells, but then there's another part called NK cells, which are also part of our immune system. These cells normally fight off viruses, bacteria, fungi, and foreign organisms. They have access to the entire body by traveling both in the lymphatic system, which is a system of tubes that are very closely aligned with the circulatory system, and they have access to really every part of the body. So they can grow in lymph nodes, and then we call it nodal, or they can grow in non-lymph node areas, and we call it extranodal. When it comes to putting lymphoma in context, we know there's about 1.8 million new cases of cancer in the United States per year, and non-Hodgkin lymphoma currently ranks as the 7th most common cause of cancer in both men and women. This translates to about 80,000 new cases per year, and we've made a lot of progress, but we do lose about 20,000 patients per year, and this is an important inspiration to try to improve upon. But the difference between the new cases and the number of people not surviving means that there's over 500,000 people who are living with lymphoma. Importantly, lymphomas affect both genders, all races, and all ages. So what causes lymphoma? We don't know in an individual all the time what causes it, but we do know that increasing age, abnormalities of the immune system, whether it's inherited abnormalities, related to treatment of another condition like an organ transplant or acquired like HIV do increase the risk. We know that there are some viruses, some of which I've listed here, chemicals and bacteria, all of which have been linked to specific types of lymphoma. What we don't know is the impact of genetics, environment, diet, and lifestyle. And these are areas of active investigation. And in particular, I think the impact of genetics is going to be very important over the next decade as we learn about some of the mutations that might increase the risk of developing lymphoma in certain families. When we put it all together, there's about 80 to 100 different subtypes of non-Hodgkin lymphoma, and I've put the lymphoma pie up here that gives you an idea of how common some of these lymphomas are. So diffuse large B-cell lymphoma is the most common, accounting for 30% of all lymphomas, followed closely by follicular lymphoma. And then we have a number of other lymphomas, which are much less common, but nevertheless something we see on a regular basis in a lymphoma clinic. So how do we make sense of all of these lymphomas? Well, one way to organize them is to look at their expected clinical behavior. So we know that despite being 80 to 100 different flavors, that in general, these lymphomas fall into one of three categories. They're either low grade and indolent, intermediate grade or aggressive, or they're high grade and highly aggressive. Low grade or indolent lymphomas are slow growing, they're incurable, happen to occur more commonly in older people, although about a third to 40% of people are under the age of 60. But these are things that grow so slowly that they are diseases that people live with, often for decades at a time. The aggressive lymphomas are faster growing and ironically potentially curable and can occur in all age groups. And then high grade or highly aggressive lymphomas are very fast growing, and some of these, such as Burkitt lymphoma, are highly curable. Now, this framework is really important, and you've probably heard your doctor use these terms, but what's important to know is that it's not particularly complete. And there are some lymphomas, such as mantle cell lymphoma, which are both incurable and fast growing, or T-cell lymphomas, which are often very fast growing and challenging to treat. So the topic that Dr. Stiff asked me to focus on is an aggressive lymphoma. So let me define that a little bit. An aggressive lymphoma is a lymphoma that grows quickly and it needs treatment either urgently or emergently. Most patients present with symptoms. These are lymphomas that people come to medical attention saying, I don't feel well. I have a lymph node that's growing. I have fevers I can't explain. I'm losing weight. I'm very tired. These are lymphomas that typically have a symptom that prompts medical attention. They do, however, respond to chemotherapy-based treatment. And many of you probably know that the way chemotherapy works in general is by killing cells that are dividing and growing. So because these lymphomas have cells that are turning over and growing, chemotherapy is a very useful tool for the majority of patients. There are many different kinds of aggressive lymphomas, and I've listed them here. The most common one, as I showed in the pie, is diffuse large B-cell lymphoma. There's a subtype of it called high-grade B-cell lymphoma, which I'm going to talk about in a moment. So if you've heard the terms double hit or triple hit, then that is what those are referring to. There's also some other aggressive lymphomas, Burkitt lymphoma, mantle cell lymphoma, and peripheral T-cell lymphomas that I'm not going to talk about in this particular 20 minutes that I was given, but I'm more than happy to address questions at the end. So how do we treat an aggressive lymphoma? I'm going to start by first saying how we approach all lymphomas and then focus in on diffuse large B-cell lymphoma. And I'll say that the first thing that's really important for anybody on this call is to know exactly what you have. An accurate diagnosis is essential. And it's also important to know that the treatment decisions are based on histology, which means how it looks underneath the microscope, the subtype that it's named, and not the stage. So you can have somebody with an aggressive lymphoma that's a stage 2, and that is a much more serious situation often than a slow-growing lymphoma that's stage 4. So stage is less important than the actual type. We also look at how old somebody is, how fast their disease is growing, and whether or not they have any symptoms. With this in mind, the goal of treatment depends on the type of lymphoma. So for diffuse large B-cell lymphoma or Hodgkin's, the goal is cure. We know that combination chemotherapy can often lead to a cure in patients who have these diseases. If it's follicular lymphoma, this is a hallmark of a slow-growing lymphoma, and it's not technically curable, but we can control symptoms and control the disease often for many decades. T-cell lymphomas and mantle cell lymphomas are a bit of a challenge, and the goal is to get patients into remission and be able to control the disease. When we have different goals, we will tolerate different kinds of therapy that we offer to our patients. So for example, for diffuse large B-cell lymphoma and Hodgkin's, we know that the goal is cure, so we are more likely to recommend aggressive therapy, including sometimes a stem cell transplant. For people who have follicular lymphoma, the goal is symptom control, and so we usually use less intensive therapy. And when we have T-cell lymphoma or mantle cell lymphoma, two aggressive lymphomas, we often have to use aggressive chemotherapy and sometimes a stem cell transplant as part of the initial treatment. So let's turn now to diffuse large B-cell lymphoma. So diffuse large B-cell lymphoma is the most common type of lymphoma in the world. This is the prototype of aggressive lymphomas. It can occur anywhere in the body. In fact, you name a body part, and I'm sure between Dr. Stiff and myself and the other lymphoma experts on the call, we've seen it in any part of the body. There are different biologic variants, though, so that's something I'm going to talk about in just a moment. But again, the goal of treatment is cure. So one of the challenges with diffuse large B-cell lymphoma is that some patients can be cured and some patients will not have the disease go into remission right away, and sometimes it will come back multiple times. So why is this very different heterogeneity of outcome? Well, it turns out that diffuse large B-cell lymphoma is probably an umbrella term, and there are many different subtypes even within this one category. So let me start by explaining some of these different variants. One is that there's at least two different genetic fingerprints when it comes to diffuse large B-cell lymphoma. So to explain this figure, this is a biopsy sample of a diffuse large B-cell lymphoma sample. And if you look at what genes are turned on and what genes are turned off, you get a fingerprint, if you will. And this was done several decades ago and then validated in patients who had received R-CHOP. And it turns out there's at least two different fingerprints that are important. Why are they important? Because if you have fingerprint type A, which here is called germinal center B-cell-like, or this other one, activated B-cell-like, people can do differently when we use even the same therapy. So maybe we're starting to get at why one patient might be cured and the other person may have to go through multiple rounds of therapy. We don't do this fingerprinting, this gene expression profiling in clinical practice these days, but what we can do is a series of stains. This is protein stains on the tissue samples, and I just put an example of some of the names that you might see if you look at your pathology report. But essentially, these are proteins that help guide the pathologist to guess at whether or not you have fingerprint A or B, and that then tells us a little bit more about how aggressive the lymphoma is going to be. Unfortunately, there is about a 20% error rate when we do this protein staining, but it's very useful and certainly a lot cheaper than doing the gene expression profiling. Now, I know in some of the questions that we got ahead of time, people had questions about something called double hit. So let me explain what that is. This is an observation that diffuse large B-cell lymphoma, again, the most common lymphoma that we see, sometimes has chromosomes that are abnormal within the lymphoma. One of these chromosomes that can be rearranged and abnormal is called MYC. And when MYC is abnormal, it causes these cells to grow. You can think about it as putting these cells, on an accelerated phase or, pushing the gas. At the same time, many of these patients or these samples also have BCL2 rearranged. And when that's rearranged, it keeps these cells alive. So it's as if the cells are growing out of control, but instead of going through the normal death pathways, they stay alive. And that leads to something called double hit lymphoma, which makes these lymphomas very resistant to standard chemotherapy. Now, there are two different ways to look at MYC and BCL2. One is that if the genes are abnormal, then we call it double hit lymphoma. But sometimes the proteins are abnormal without the genes, and then you might see this term called dual expressor lymphoma. Patients who have dual expressor lymphoma may not do as well as people who don't have any of these abnormalities, but the outcome is not nearly as bad as it is for double hit lymphoma. And to be honest, this is an area where we don't know the best treatment. We know that R-CHOP is good, perhaps not great, but we don't know what is better. So there's a lot of trials going on to try to figure this out. My approach to aggressive B-cell lymphoma is really focusing in on diffuse large B-cell lymphoma when patients are first diagnosed, is we always test for MYC and BCL2. If, regardless of whether or not these are positive, as I was saying, we don't really know what the best treatment is, but we will give R-CHOP chemotherapy as our standard approach. And we will also consider something called central nervous system or CNS prophylaxis. The reason to include this in our approach is that we know that R-CHOP chemotherapy is very good at treating lymphoma in the body, but if there are lymphoma cells that are in the brain or the fluid around the brain, we often need to use some other type of chemotherapy that penetrates that area much better. That's called CNS prophylaxis. For high-grade B-cell lymphomas that have the chromosomes abnormal with MYC and BCL2, this is what we call double or triple hit lymphoma. And what we know here is that R-CHOP is not good enough. And there's a number of different treatments or recipes, if you will, that can be used in this setting. The one that we use here is something called dose-adjusted EPOCH-R. You'll notice it has all the same ingredients as R-CHOP, right? R-C-H-O-P, but it adds in this E, and it's given in a dose-adjusted way, which means we dial up or dial down the chemotherapy based on how an individual does. And it's also given as a continuous infusion instead of all on one day. And again, we know that these lymphomas can sometimes set up shop inside the brain. And so we always have to think about whether or not to give some type of prevention to help protect our patients. So what if the disease does not respond or comes back after this initial treatment? Well, there's several different approaches, but the standard of care today for the first, for what we call second line treatment, which means the first line R-CHOP type therapy didn't work, but it comes back, is to do something called an autologous stem cell transplant. And the way that I usually explain this is that there's 4 components. There's 4 parts to this. The first is that we have to get patients back into remission. We have to get the disease under control. We give something called salvage chemotherapy. The goal is to get the disease into remission, and there are several different examples here, and it's not really clear which one is the best, although I do think rice is the one that people use the most. The second step is to collect stem cells, and the goal is to get 4 million CD34 positive cells per body weight, and often there are some growth factors that are used to help get these stem cells collected. The third part is the actual workhorse. So this is where we, there's good data that more chemotherapy can get rid of some of the most drug-resistant cells that are there. So if they don't respond to R-CHOP, but they do respond to the salvage chemotherapy, we can give very high-dose chemotherapy, get rid of any resistant cells, and then use the stem cells that have been collected ahead of time to rescue the bone marrow from the side effects of the high-dose chemotherapy and have a second chance for cure. And I put some examples of the chemotherapy that could be used in that setting. And then finally, there is a period of recovery and re-immunizations that usually is performed over a 2-year period. Giving or doing an autologous stem cell transplant has been the standard of care really since the mid-1990s. However, as we're going to hear in the next talk, not all patients are well served by an auto transplant. For one thing, R-CHOP is a very good therapy, and if it is not enough to get rid of the lymphoma, the whole concept of more is better is being challenged. And this is where CAR-T is really being discovered, or has been FDA approved and now being expanded in terms of where it could be best used. And that's going to be the topic of the next talk. Let's see. So what about patients where an aggressive approach like autologous stem cell transplant, CAR-T, or something else is not appropriate? And this is a significant portion of patients. Either patients may be older, or you might have organ challenges or other reasons. But if intensive treatment is not an option, I think a clinical trial is very important. However, on a positive note, we do have 3, and I put them in green, newly FDA-approved options in the last year and a half. The Pola-BR is a combination of an antibody-drug conjugate, something called polatuzumab, added to bendamustine and rituximab. This is an outpatient therapy that can put patients into remission and control the disease. It is not a cure, but it is very effective in putting the lymphoma into remission. Selinexor is a tablet that can be taken that also is very effective in this setting. Again, not a cure, but can help control the disease. And just in the end of July, we had tafasitamab plus lenalidomide FDA approved. And this, again, is another option for patients where aggressive therapy is not feasible. So to summarize, lymphomas are a complex family of blood cancers. A biopsy is really important. We don't really know why lymphomas develop in most people, but it's something that I think is a really exciting area. Staging and prognosis are important, but of course it's really the type of lymphoma that's more important, and there are many new treatments that are based on better science. I put this in here. You're going to have access to my slides. This is sort of my algorithm for how we approach diffuse large B-cell lymphoma. I took out all of the clinical trials we have at the University of Chicago, but we do have 3 trials for people who are newly diagnosed. We have 1 trial here for early relapse, and we have about 4 or 5 trials for patients who might be in this category. So there's a lot of very exciting developments right now. I do think it's an encouraging time for aggressive lymphomas, and appreciate the chance to talk to you about it tonight. So with that, I'll stop and turn it over to our next speaker.